حل صوتي. Vasoconstriction بحط لكم local anesthetic with this one. حتى sometimes if you take this injection you will feel increase in heart rate. Now we finish alpha 1 vasoconstriction. What do you think is related to heart? Which receptor? Beta 1 stimulation or inhibition? أيوة كويس. You are talking, you are saying it so that you remember. Always when you want to activate the heart, we give what? Beta 1 or beta agonist or antagonist? I remember I said it for you. So if you say increasing vasoconstriction, why this one you want to say it's sticky? Okay, what can you say about the heart? Beta 1, remember, it's what? The receptor depends on the organ where they lies, so you can relate the effect. So remember, when it's sympathetic, it's what? Alpha 1 vasoconstriction. Beta 1 is what? Increasing heart rate. Do you usually think, and we use the beta 1 agonist more or the beta 1 antagonist more? The antagonist more. You will hear it in the Thursday lectures. What about the beta 1? In case you need a cardiac stimulant, okay? Do we use epinephrine? No, we have more specific. So you go more into dopamine and other medication, which I'll mention it and I put it in red. So remember, alpha 1 is vasoconstriction, beta 1 is what? Heart. What about beta 2? Bronchodilation. فلو حدا asthmatic, we'll give them what? Or somebody have a bronchospasm, we give them what? Beta 2 agonist. So you have to remember this. Also, if it's related to uterine, there is a table that I put for you all the effect, but I circled the most important fact that you remember it with the sympathetic. So let's say if somebody, we give him epinephrine. Okay, what will happen to the blood pressure? Increase. What will happen to heart? Yes. What will happen to the, if it has alpha and beta? Epinephrine has an alpha and beta. If it's on the respiratory system. So somebody, if it has any severe bronchospasm, if we give him an epinephrine, so that's why you will find it always in the emergency, so or in the ambulance, they will give epinephrine. So what happened if you have a severe bronchospasm? What will happen? Bronchodilation, and then at the same time, what will happen? They should worry about what? Increasing the heart rate. Okay, then it's a stimulant. So these are the main one. Now we have indirect. So now we are talking about medication that act what? On the alpha and beta. That stimulate alpha. If it stimulate alpha 1 is the vasoconstriction, increasing blood pressure. If it stimulate beta 1 is the heart. If it stimulate beta 2 is what? Respiratory. Also remember the uterus, also we will use it. And respiratory, you will hear more about those medication, respiratory block. Also in the OB-GYN, you will hear about stimulation of the uterus. They will use also those if you need relaxation for the baby. For the uterus, so that they will not have, if they have premature. So I'll mention it, but which is more important to me now, the blood pressure and heart rate. What else I want you to know? Okay, so we are talking about acting on the receptors. What about now? Okay, this one, I think we described the social function, and I've checked Dr. Dilip and Dr. Mal, I will emphasize more on the medication. This is where really I already have the MCQs. Sympathetic neurotransmission, so you know norepinephrine is from the post-ganglionic of the sympathetic. What about the adrenal medulla? Itself, it's a ganglia by itself, you know it, and it releases what? Okay, but the epinephrine more from the adrenal medulla. Okay, so we know that the sympathetic is a part of autonomic nervous system from peripheral, which it's one of the organization of the nervous system. I don't need to repeat what they. This is what I was trying to tell you, that the sympathetic will release acetylcholine, and you know it's nicotinic and the release of norepinephrine, which act on adrenergic, and we know adrenergic can be alpha 1, beta 1, or beta 2, or whatever, or alpha 2. We know alpha 1 is vasoconstriction, alpha 2 is autoinhibitory, beta 1 for the heart, beta 2, you should not forget this. Next year I teach, or next term, we should always remember alpha 1 is vasoconstriction, beta 1 is, it should go forever with you. Now, what about, we talk about the adrenal medulla itself, it's the ganglia, but it releases what? Epinephrine into the blood. This parasympathetic already, they cover it, and the somatic, you know, it releases, do you know what's nicotinic receptor, this one? Is it an like this one? And so do you think we will give us, why we don't give acetylcholine? Is it preferable to give acetylcholine? No, because it acts on all over the brain. Okay, this is where the acetylcholine acting on NN. I don't need to repeat it. This is what the pre-ganglionic fiber, and this is the post-ganglionic fiber, where you have the adrenergic receptor, whatever it's alpha 1 or beta 1, and it's a G protein couple. So I'll mention the GQ and GI, and then you have the norepinephrine. Is that clear? This is the adrenergic system, and I'm seeing maybe Dr. Dilip, the cholinergic. Now, how it will start the synthesis, norepinephrine, how it will be released? Can someone recall the major parts? Yes. Yes, she answered me. So, okay. So you have first from tyrosine, it should go directly to what? You have different steps, different enzymes. Remember when I covered the lecture of where drugs can act? One of them is the receptors. Remember, and we have different types of receptor. These are the receptor of G protein coupled, and I told you that it might act on what? On enzymes. So any inhibition of this enzyme, what will happen to the whole step? It will be inhibited. Okay. And then you have the dopamine. The dopamine, where you will have the synthesis of norepinephrine, outside or inside? It should be inside. Do you know why? You have, remember, MAO, which is the enzyme that's metabolized the norepinephrine. So if you keep the norepinephrine outside the storage, what will happen? It will be, here there is one important medication. You have to remember it. You cannot keep the norepinephrine outside. You have to bring it to be synthesized. It will be synthesized. If you have the storage, you should have other components or ATP or contransmitter, I'll mention it, so that you have norepinephrine. So, and then what happened to norepinephrine? Exocytosis, release of norepinephrine to act on F1. So now okay, so we know the whole neurotransmissions. What will happen? We cannot keep norepinephrine always stimulating. What should we have? Always either degradation by certain enzyme as the MAO, or COMT, which I'll mention it as well, to remove the norepinephrine, or what? Or they act on alpha-2s, they will be auto-inhibitory, or you have an uptake. So if I tell you uptake 1 inhibitors, what will happen? You have more norepinephrine or less epinephrine? More norepinephrine and so it's more stimulating and stimulating, okay? So what do you expect the person who's taking uptake 1 inhibitors? More, so might be more increasing blood pressure, more heart rate, and so on, depending what, okay? Is that clear, the whole concept of neurotransmitter? I don't want you to memorize the medication. Just go with the flow, how they will act, how they are synthesized, and where are the major medication that I need you to remember it in the sympathetic. So the adrenergic drug, remember, they affect, they are stimulated by norepinephrine or epinephrine. We call them sympathomimetic, or we call them adrenergic drug, which act on what? Receptors. We have a direct acting. What does it mean, direct acting? They directly act on the receptor, which is the norepinephrine and epinephrine. We have indirect acting. What do you expect that to have an effect of indirect acting?
By affecting the enzymes, like degradation enzymes.
So not anything that has nothing to do with the receptor, indirect acting. And then we have mixed action. It means both direct and indirect. They are affecting the, so guess if it's you have a medication that will increases the adrenoreceptors and we have more norepinephrine. So it's more excitatory effect. We have the sympatholytic. We know that sympatholytics, mainly you will hear about them Thursday, about what? More blockers, blocking and more into the heart. Now, do you know why we have alpha-1B or alpha-2? You remember adrenergic receptor, we say alpha-1, alpha-2, beta. We know the alpha-1 is vasoconstriction, please remember it. Alpha-2 is auto-inhibitory, and we have beta. Beta-1 is related to what? To the heart, and beta-2 is more bronchodilation, and beta-3. So if I give you a beta, well, you should know it. It looks like you're a great batch. So if you give you beta blockers, it blocks beta-1, beta blocked, non-selective. So why we go to selectivity? If you want to block the heart rate, which is better, to give a beta blocker that blocks beta 1 and beta 2, or to give just only to block the beta 1? More, we are preferring always to have this selectivity where you will find alpha 1 or alpha 1A, even subselectivity. So if you give a patient, asthmatic patient, a beta blocker, non-selective, what will happen? Someone else. وانت someone else خلاص. Find someone اللي جالسة آخر شيء. She's using her telephone. Can you? Yes. Tell me what was my question. Okay, somebody answer me. Can you explain the mechanism? If you have to know the mechanism, just don't memorize that, because it increases the heart rate, it decreases the heart rate, which beneficial if you wanted to decrease the heart rate, but at the same time it's not selective on the heart, so it's not blocking what? The beta 2. The beta 2 effect is what? Activation, bronchodilation. When you block it, you will have bronchospasm. So somebody with asthmatic, you should avoid taking, or cautious taking propranolol. That's why we have those selectivity medication to have more into heart or into the respiratory. So this is what we start. We talk about the neurotransmission, the whole pathway. We have to synthesize norepinephrine, remember, and then we have to store it in the vesicles, and then we have to release it. The release of norepinephrine, it will wait for what? Action potential and what? Calcium. And then what will have to bind on receptors, but it cannot bind the receptor and activate. It should be degraded. We remember that we have to remove it and metabolize. It should be removed by reuptake, remember, and reuptake, which is uptake 1, and then it goes back again in the store till another action potential. And then some of them, they will be what? Metabolized. Is that clear? This is all what I've mentioned, but you have it all details. Remember, norepinephrine, it comes from tyrosine, and then it will be converted into dopa. This is what we call it, hydroxylation of tyrosine is the rate limiting step. And then dopa, it will be converted to what? The dopamine, which is entered the physical converted to know where it will be converted. Remember, one example. So why we cannot have the norepinephrine? Because of the mouth outside. If it is converted outside, it will be degraded. So it will be stored and then waiting for action potential, calcium entry, exocytosis, act on a postsynaptic. And then when it's finished, if we have norepinephrine, if we have presynaptic receptor is inhibitory or excitatory. Inhibitory of the norepinephrine, and then we have the metabolism by bow and count. Is it clear now, the whole process? تفضل. تذكر أيامكم no one will enter after that. بس هدول عشان online ولا الأونلاين أعرف مين موجود. He knows no one can enter after 5 minutes. Synthesis بس بالكورونا. So the synthesis is the same thing. أنا usually let me tell you the way, I don't know how you study, everyone has, if I want to prepare something new or never give it up, usually I go with the general picture and go more into details. You don't need to follow my way, you can go into details and make your own general. And usually no, when I read something, I'll just draw the general outline that I need to know it or what I need to deliver to you, and then I'll go to each step details. And then later on, when you want to study from the book, and not from, then later on you will go to the book and need to study. Some of you, they will go and read each paragraph by its own, they have to understand it all. And myself, I will never do it. I will just go the whole chapter, read it all, understand it as a whole, put the main points, and go each one by one. If something is not clear to me, I go to another book to make it sure or to go up to date. And this is a general rules to me, but it doesn't mean it applies to you. You have to find a way that, because I know we have a lot of, and you did not pass the POD, but I worry about you. So you have to make sure to find your way, the best way to study. It doesn't mean the way I'm telling you is the best way. You have to find your way. Different people, they have different way of studying. So now we go to synthesis of norepinephrine. Remember, we have tyrosine is transported by sodium tyrosine co-transporter. So anything can inhibit sodium tyrosine co-transporter. What will happen? So less norepinephrine. Remember, if you find any medication later on in any upcoming block, so anything affecting, remember, the drug can affect what? Receptors, and what else? Enzymes. Before enzymes. Okay, or carriers. Carrier is the same thing as transporter, and then receptors. And then receptors, you have different subtypes of receptors. Tyrosine is converted to dopa by tyrosine hydroxylase. So anything affecting these enzymes. So now we talk about transporters, we talk about enzyme. This is your rate limiting step. Dopa is converted to dopamine by dopa. No.
Okay, any drug that inhibits the sodium tyrosine, do we consider direct or indirect?
انت
Direct?
طبعا مش direct على الانزيمز depending if we're talking direct on the receptors that and I want to know it as a medication. By the way, this is the way they categorize the medication of the non-adrenergic. So you have direct and indirect. But if you're talking about the enzyme transporter itself, so it's direct on the transporter. But if you're talking about the neurotransmission sympathetic, so you get the bigger picture. It's not directly you're blocking the norepinephrine. You're what? Affecting something in the back. Then dopa is converted to dopamine by dopa decarboxylase. Dopamine, so dopamine is used, you will hear about it in the Parkinsonism, MSI, L-dopa. I don't know if somebody from the family, from your grandfather or mother, they have any Parkinson's, they will take this medication, which is a precursor of what? Norepinephrine. Okay? In adrenal medulla, remember, norepinephrine is converted to epinephrine by another enzyme. It's not the same enzyme. Now, the storage, we know that we mentioned that we have the dopamine will be converted where? Inside. So we have the dopamine now, and we need dopamine beta hydroxylase. So if you don't have in the storage itself the synaptic vesicles, which is inside, the dopamine beta hydroxylase, it will not be converted. But it doesn't mean only this. You have to have ATP, other co-transmitters. I don't know if somebody mentioned for you about the co-transmitters. And it's not like that. Usually co-transmitter, they go along with other neurotransmitters, okay? We call them co-transmitters. Enzyme contribute to this reaction within the vesicle. So inside the vesicle is not only just converting dopamine with the presence of dopamine beta hydroxylase. Remember that inside the storage we have other components which and you will know it later on. I don't know how much is important later on to know, but you have to remember, I mean, not the details, it's the concept. So it's stored at high concentration, so we have a lot of norepinephrine in the storage, waiting for action potential. So before, reserpine was one of the first medication to decrease blood pressure. So it's transported to vesicle occurs by reserpine sensitive carrier. Okay, so this is something which is related more. How do they know where this medication they act? Do they block, or it's on the vesicles, or like this? Reserpine, it was one of the first medication. And then remember you have the exocytosis. Now binding receptor, we know alpha 1 is what? Vasoconstriction, and we have alpha 2 is more subtypes. We'll hear more subtypes later on when you take your upcoming blocks. If it's depending on if it's related to OB/GYN, you might hear depending on what's found in the uterus. If you're taking respiratory, you will hear more what's found in the respiratory system. If it's on the heart with the cardiopulmonary, also you'll find more selective medication that acts more not on alpha. We say alpha. We start to say alpha 1A, alpha 1B, and so on. Now, more subtypes for selective drugs. We have, this is one of the medication, I will put it in red. Usually the medication that I want to, no, I cannot change it, so let's leave it. And usually I put for you all the medications, but this one, remember it, it's recorded. Tamsulosin, as we use it for benign prostate hypertrophy. This is one of the medications. I'll not go how it will act. You will hear about it, but just an important medication when we use it, and it's alpha 1A. And then we have beta 1, beta 2, and beta 3. And yesterday I was going to add beta 4, but there's not so much. But remember, you might find, عشان not somebody he reads a lot of any articles, you might hear about beta 4 or maybe something beta 5, but still not yet. We find it in the book and we have a lot of documentation. Now the major action, this is what you see, شايفين red. No one come and ask me, do I need to memorize the whole table? So alpha 1 is a GQ, increasing vascular smooth muscle. GQ and GI is related to what? Okay, is it what is it, calcium, which one? Remember this. Okay, you have to relate what I give you to this one, GQ and GI, okay? Anyway, I mentioned it later. Alpha 2 is decreasing sympathetic adrenergic outflow. Beta, that's why here when you have alpha 1, we have vascular smooth muscles, the pupillary dilator, intestinal bladder sphincter muscle contraction, okay? And then in the beta 1, remember what? The heart rate. So anything it will be increased cardiac output, and we have also renin. But what I need you to know from this, my lectures, and what I need the MCQs, this you will know more the details later on. But you have to remember clearly the sympathetic, vascular, which is alpha 1, outflow autoinhibitory alpha 2, beta 1 is the heart rate, and then beta 2 is what? Is the bronchodilation or vasodilation. And also remember when I tell you decrease uterine tone, which you will hear about it in the OB-GYN block. And the beta 3, I don't know if we have certain medication that we will give it to, but this is the one that it should be memorized by heart, okay? Now, removal transmitter of factor stimulated by reuptake, inhibited by cocaine. So people that are taking cocaine, what's happening? We have more and more norepinephrine. So I will tell you now how they're acting the cocaine. Norepinephrine release is controlled by what? Alpha 2 activation. When activated, it causes negative feedback and inhibit release of norepinephrine. Agonists will inhibit release of norepinephrine. Anatomy, this is the way I like to understand the whole pathways. What are the receptors, the major one, and then you have to go memorize. Remember, alpha 2 is related more into inhibition. Remember, I told you that we have enzyme, which is the monoamine oxidase. Remember, we find it in the synapse. That's why I told you if we don't have it in the storage. And then you have the COMT, which is found where postsynaptic. Reuptake and enzyme are responsible for what? Catecholamine removal. Again, this is another pictures. Remember this one, any different picture in the book or different places, you will find it depending on what they want. In this one, it's more, they're telling you where are the medication acting mainly. So we are not going into tyrosine, and they're overstepping directly to norepinephrine, and they're keeping the norepinephrine. It should be where inside. Okay, so we have here certain, when you see negative, what does it mean? Either negative or dotted line, what does it mean? Inhibitory in any figures. Or if you see a plus, it means it's stimulating more, and or if you see a full line. So now here there's no dotted line where they act. MAO inhibitors, you have the reserpine, the alpha adrenergic agonists, antagonists. So an alpha 2 agonist, it would lead to what? Alpha 2 agonist. What does it do? Increase or decrease? Decrease the release. So it's good in, if you want to use it in decreasing blood pressure. But I'm telling you, we never use something which is acting. The more you hear about medication now, you're more into selective medication, and you want to target the organ that you need it, and plus you have less side effects. So if you have an antagonist on alpha 2, more than you have the antagonist alpha and beta, you have uptake inhibitors, and so on. This is a general where the medication could act. Now, to type, we said catecholamine. What are the we have non-catecholamine agonists and catecholamine. The catecholamine, which is epinephrine, norepinephrine, and dopamine. You remember dopamine, it was a precursor of norepinephrine. You have we call it isoproprenol, between the British and American, and or isoprenaline is a synthetic derivative of norepinephrine. And I'll tell you what are the difference between epinephrine and norepinephrine. It's their affinity to more alpha and beta. All of them, they act on alpha and beta, but some of them, they are more into alpha. The most important, you have to remember which one? The epinephrine. Okay. Higher potency, rapidly inactivated, and poorly under CNS. Sometimes you might find any side effect, but they are poorly. Non-catecholamine, which is not, now they are catechol and non-catecholamine, which is structurally related to the catechol, okay? Direct or indirect or mixed, they have longer half-life because not metabolized. Now, the catecholamine, the most important one, remember, noradrenaline or norepinephrine transmitter released by what? Sympathetic nerve terminals. Adrenaline is the hormone released by what? Adrenal medulla. The dopamine is metabolic precursor of what? Epinephrine or CNS. You can find it in CNS neurotransmitter. It's also a neuromodulator. It's found also in the periphery, dopamine. Isoproterenol, or we call it isoprenaline, is a synthetic derivative. No, not found. We don't have isoprenaline. So this is the difference when we say epinephrine, norepinephrine, and isoproterenol. Remember, epinephrine and norepinephrine, they are found in the body, isoprenaline or isoproterenol. Epinephrine, it has more affinity into alpha. That's why in cardiogenic shock, what we will get, epinephrine or norepinephrine? Or you have bleeding, or which one the most vasoconstrictor, epinephrine, you think, or norepinephrine? They have more affinity into alpha. So the epinephrine. Also in the beta, you have the isoproterenol and the epinephrine and norepinephrine. Still the epinephrine, that's why I circled for you. Now the alpha receptors, remember, it's a GQ. Please relate it to my older one, second messenger, phospholipase C activation, IP3, increasing calcium. I just put it for you, that's just to remind you, alpha 1 is more into increasing calcium. Alpha 1 activation. Remember, alpha 1 activation, this you have to memorize it. Constriction of what? Vascular smooth muscles, skin splank, vascular bed, larger arteries, vein, as well arterioles, except what? The skeletal muscle is not affected, which results in decreased vascular compliance, leading to increased peripheral resistance. This will increase what? The blood pressure. Now, when you say inotropic and chronotropic, do you know the difference? Inotropics, it means the force of contraction, and chronotropic on the heart rate. Both of them, if you increase them, lead to cardiac output and cardiac oxygen consumption. The more details of this medication or which alpha activation like this, it's more related to what you think, which block? And blood pressure, the cardiac, okay? Now, we have an alpha-1 selective adrenergic agonist, which is called phenylephrine, used primarily as nasal decongestion, as nasal spray, or sometimes oral medication. Some of these medication, you can find them, the Panadol flu, I don't know, a combination of medication, you take it OTC, and if I take from this medication, yes, I'll have nasal decongestion, but on the spot, I'll have increased heart rate. A call for short term, remember, when you use anything for nasal decongestion, how many days you can use it? Maximum. Nasal decongestion, spray. Maximum. Because they will have, you use this nasal decongestion. Never ever. 1, 2, maximum 3 days. You never use it, and usually they prefer to have normal saline because you will have severe rebound congestion. Now the alpha 2, which is what? The autoinhibitory. So you expect to be GI. The other one is decreasing in what? Cyclic AMP. So remember all the details of it from my previous slide. Now alpha 2 selective agonist, which is alpha 2, alpha 2, alpha 2. So you are inhibiting what? The what? Alpha 2 agonist, inhibiting what? The release of what? Norepinephrine. You don't have norepinephrine. So mainly before used as a central acting antihypertensive, but it's not anymore the first one. So it was the clonidine that they use it. It's clinical effect linked to CNS activation of alpha. Sometimes, by the way, it's not A2, it's alpha 2. Then changing the symbols from place to place. A nucleus of solitary tract, decreasing sympathetic outflow to periphery. And it was used, this one medication, but now we have better medication to be used and decreasing blood pressure. Now, this is the alpha 1. Remember, where the DAG and IP3 and the calcium, and this is the alpha 2 to remember, where you have the adrenaline cyclist to remember the mechanism of action of any medication. Now, I don't know if Dr. Manal or anyone will tell you which is the most dominant, while you're sitting on, which is usually the most dominant neurotransmission that we have? The parasympathetic. So mostly you're relaxed, decreasing heart rate, and more you might drink water, donuts, okay, or drinking. So it's relaxing and decreasing heart rate, and GI motility is more. The pupil should be constricted or dilated. Okay. So, but remember, and I don't know, I was going to remove it, and then I said, let me leave it. And usually, when I cover the autonomic, sometimes they give me to cover the autonomic, nervous system, cholinergic, and sympathetic. So, it will be a whole flow to me. Now, because Dr. Dilipi takes something, Dr. Bonachi took something, and I was giving the cholinergic, and then they changed. So I kept this one just to remind you. When we say norepinephrine, when it acts on postsynaptic receptors, but we cannot keep the norepinephrine always stimulating. We have the what? The auto what? Inhibition, at least to control this neurotransmission. This is a regulation for the body. Also remember, the parasympathetic, it has an effect on this neurotransmission to keep always a control and balance of the sympathetic. If it happens any imbalance, you might have. But this is, remember it, also you have the sympathetic is acting also on the parasympathetic. We call it homotropic and heterotropic interaction between sympathetic and parasympathetic. And how much it's important, to me, I'd like to keep it, and you might hear it, at least I mention it for you, okay? Beta receptors, although through G stimulatory, remember it's a G stimulatory, stimulates cyclic AMP, only beta 1 in the heart. We have beta 1 only in the heart, we have nothing. So if we want to give something that acts on the heart, it's better to give what? Beta 1 selective. And we have both alpha 1 and beta 2 in smooth muscle, bronchi, skeletal muscles, okay? Remember beta 2, remember when I tell you we give epinephrine that acts so when you give anything more into bronchospasm and into more bronchodilation, you give what? A beta 2 selective, so that will be in the smooth muscles. Now, beta 1, it has equal affinity to epinephrine and norepinephrine. Beta 2, higher affinity to epinephrine. Beta 3, more into lion pulses, you'll hear about it. Beta receptor agonists, we have selective and non-selective. But always remember that we are favoring what? Selectivity of medication. Now, the direct acting beta, we have the non-selective, remember, these we're talking now agonistic effect. Isoprenaline, they are non-selective. Remember when we say isoprenaline has both alpha and beta? If we're talking beta 1 selective and we said dopamine, so now dopamine, it will be a what? Increasing heart rate. What can we call it? Cardiac stimulant. So now if we need to be more selective into heart, somebody, it's not cardiogenic shock, which is like we'll give the epinephrine. We want something to the heart actually. You prefer to give epinephrine or dopamine? Dopamine. Now.
So why did you mention that inotropic effect of what agonists shouldn't be beta 1?
Where did I mention it?
I think in the slides for alpha 1. Unless you're just trying to explain it.
I didn't, did I? Send me an email, or I'll check it now when we finish the lecture, okay? So if you're talking more into the heart, we go cardiac stimulant. Now, if we want to talk and we want more favoring the respiratory, we go into what medication that acts in the beta 2. And remember, the beta 2 is found also where, other than the respiratory, in the uterus. So when we need to if you have premature labor and you want more relaxation of the contraction, we give them those medication beta 2 selective. You have, if anyone around you asthmatic like this, they will take terbinafine and salbutamol. Now, the non-selective beta agonist, we have isoprenaline, which is non-selective beta receptors. It causes bronchodilation, but as well it increases what? The cardiac output. So we prefer to have selective bronchodilator rather than to have less. If we're looking for something cardiogenic shock, we go into what? Epinephrine. I'll explain for you why. They are metabolized by conjugation, reaction phase 2, and not by COMT, the azoprenaline, okay? Non-sensitive to OMAL. We can give them oral, parenteral, local. Let me tell you, I put it for you because before they were using those medication, and you'll find it in the book. Or sometimes when I hear from the TAs, or they said there are things that really we should not mistake, and they will find it in the step or UCMLE. They will give you this azoprenaline, how it will act. Then it was used for asthma or obstructive pulmonary. Now with the COPD, we have more selective medication, or cardiac stimulant, you have more, much better. So now it's used, it's obsolete. So I kept it because it was the first medication on to act. Now, selective beta-1 is the dobutamine, which is a synthetic catecholamine used in acute congestive heart failure. This is not the only medication that you'll hear about it. When you take the cardiopulmonary blocks, you'll hear more about this medication. Can be used in cardiogenic shock, okay? Because it's positive inotropic action, increases contractility. I'll not go into detail now. Does he teach you, Dr. Hamdan? No, ما بدي اسمه دكتور حماد. Okay. The other day I've seen him, he's putting the American flag. He took my pen, the Saudi flag. I give it to him, showed it to him. Okay, now beta-2, remember, beta-1, we said what? It's more in the heart. Beta-2, we have the terpitalin, or I mentioned salmeterol, and you will find more medication. They are bronchodilation, non-metabolized by MAO or COMT. A longer duration of action than isoprenaline, administration oral parenteral inhaler, and most of these medications are given by inhaler. Used in asthma, COPD, we have the terpitalin. Terpitalin is used as two-qualitative, prevent premature labor. You will hear it in the OB-GYN also prevent those medication more, which are acting on beta-2, where not the respiratory fetus. Now, from this table, you see the red, which is related, but if someone who wants to know each one, how they will act, epinephrine, isoprenaline, norepinephrine. Norepinephrine is not used clinically because it's mainly on alpha. We use usually epinephrine, remember in what? In anaphylactic shock. If somebody has severe bronchospasm and about total closure of, with local anesthetic, or even in the ER, if you have a severe bleeding, you know what they break the ampoule of epinephrine. I drop it on any area because they will cause local vasoconstriction. So now, epinephrine, remember, it acts on both alpha and beta. The alpha one, we have vasoconstriction, and also beta-2 is vasodilation. The one I did not put thread to colors, it means, and I just keep all details so that you understand the flow. But the most important that you remember the concept, and you will take it more and more later. So the overall blood pressure for epinephrine is increasing blood pressure, the overall. Remember that blood pressure is not related only to the heart, and you have also renal blood flow, and what else? The kidney, but the overall you have is increasing in blood pressure. And also the heart rate, because the beta-1. So remember, when somebody you're giving him epinephrine, he might go into dysrhythmia or fibrillation. You have to be careful, but it's a powerful bronchospasm. And I remember, one time my son, he was 11, 12 years, and we were, I don't know, in a place that there was calling. All of a sudden, he started to cough. Wallahi, within 1 hour or 2 hours, he started to have total closure. We were in an island, there is no, I don't know, somebody comes and they put for him directly the epinephrine, okay? It was, you can feel it the way I can feel, he can relax the bronchodilation, so that's why I will never forget this medication. But the heart, it was, like it's bump, I can see it like this. I was worrying that really it would go out from his, and then they took him again, and we took him to another, to the main because we were an island. So I remember it very well. They give him the epinephrine, and then they give him also steroids and like this, because it was from, but really it's a powerful bronchospasm, but at the same time, that's why you have to give it through what? And it's not an injection, مثلا like, what do you will use to control those medications? Do you remember? Do you know? Okay. So you need to go, yeah, you cannot give it like one shot. Okay. This is the epinephrine. I put it for you. Remember the isoprenaline? I said it's obsolete. It has beta 1. It has beta 2. It can, but we don't use it now because we have better medication and more selective medication. The norepinephrine, it doesn't have any effect on respiratory. And if you want to increase the blood pressure, we have better the epinephrine. Or if you want to increase excitatory, we have better on the heart. And because we have better and more selective medication, and they might use it in shock, but usually they're preferring, you don't use the norepinephrine, epinephrine. So from this table, just what you need to remember, the red one is the other one is for you to understand how they will act. Now, the indirect acting, they potentiate norepinephrine release endogenously. We have the amphetamine, tyramine, and cocaine. Okay, amphetamine is essentially stimulatory effects. Now, when you will go in the ER, they will tell you this of drug of abuse, but it's one of the medication they will give it in ADD, attention deficit. When you take neurology, you will hear about the amphetamine. How it will act, I will tell you more in details, but they are indirectly acting, so we are talking more nothing on the receptors. As you see, the direct acting is on the receptor. Tyramine, it's a very one, really is important. Few people, let's talk about it here, in the Western, they take antidepressant. Some of the antidepressant, they are what? MAO inhibitors, okay? So MAO inhibitors, you don't have MAO to degrade them. And some food, the red cheese, the wine, they are rich in tyramine. So this one, they can cause anyone, and it happens, they are in the restaurant, it's very well known. They're sitting enjoying their time, and all of a sudden they have increased norepinephrine because the tyramine is indirect acting agonist, and you don't have the mouth to degrade it, so you have more release of. But they will not know that because they're taking antidepressant, but they always make sure that who's taking, they will tell them do not take it with alcohol, high dose of alcohol. Or we have ripe cheese. The ripe cheese, the blue cheese, or this one, especially in the Western, they eat it. The cocaine, they prevent the uptake of. If you prevent the uptake of norepinephrine, what will happen? And drug of abuse, honestly, cocaine, but tyramine, you can because some of the antidepressant plus the amphetamine still a drug of abuse. But that's why my students, they take it during the exam. What will happen? They will stay alert or excited or rich because of indirect acting. They have more norepinephrine. Now, amphetamine, how they will act on tyramine, okay? They enter by uptake. Remember, I told you they enter by uptake. Uptake, to take norepinephrine, you don't want to keep it at the level of the receptors. You will take it back to the stores. So if they enter with this uptake, they will enter with the uptake. And what happened? Also, when they enter the storage, and they also release the norepinephrine. So they enter by the uptake, and then enter the stores, and the more on norepinephrine release. So they enter by uptake. One displaces noradrenaline from vesicle, allowing it to escape. So you have more norepinephrine, therefore potentiating norepinephrine effect endogenously. It's not that this is not a direct effect on postsynaptic. It's more into what you have the transmitter and the storage. Now, indirect acting, this when I tell you if you're taking phenlazine, selagine, and now those medications, they are not widely used, by the way. As a antidepressant, we have more, have better medication, but they were used. They are MAO inhibitor. If you co-administrate with other indirect acting drugs, can lead to hypertensive crisis. If we said indirect acting, or we said it could be something they're eating that causes the tyramine. So if you're stopping the MAO, you will have more norepinephrine release. That's why you will have hypertensive crisis because of the effect of what? Alpha-1 activation. The mixed one, you have ephedrine and pseudoephedrine, or these are usually in nasal decongestion. Also, that will stimulate both receptors, they displace norepinephrine. That's why I tell you their side effects mainly if you take it as nasal decongestion. These medications, they were banned in 2004, but they are released again in the market. And like what happened, they will tell you this, you cannot use it, or they cause this cardiovascular problem. No, they cause a cardiovascular problem if you have any cardiac patient, if you are a cardiac patient, but if somebody normal should not. They were banned and then they were released again. So all these medication you find it pseudoephedrine and ephedrine. Any medication that for flu, you will find them in the market. Now, dopamine, remember, dopamine is what? Precursor of norepinephrine, and also activate both alpha. We have dopaminergic receptor, D1 and D2, are found in renal vascular beds causing vasodilation. In different ways, affect dopaminergic or adrenergic or both. Remember, in the major D1, it relaxes vascular smooth muscles, but remember in D2, you'll hear about it when it comes to Parkinsonism and L-DOPA. You will hear more about it. D2. The D1 is more related to what? To the vascular smooth muscle. Now, the adverse effect, remember, you should know it. Arrhythmia, headache, hyperactivity, insomnia. That's why they will take this amphetamine to stay awake, but they can be having nausea and tremors. These are the major side effects of adrenergic agonists in general. Now, from this one on, and now I'm towards wrapping up, I just put for you this one. What I need you, so that don't ask me what do I need to study. Remember, if the heart, we are talking about beta 1, everything is increased, heart rate, cardiac output, contractility, and everything, okay? If we talk about bronchial smooth muscle, is what? Beta 2, bronchodilation. The opposing, it will be the cholinergic receptors. It should be covered by Dr. Manar. Now, there is the effect on kidney, liver. You see, if it's on the heart, it will be what? Increasing. But if it's on the bronchial smooth muscle, it's what? Bronchodilation. Remember, in uterus, I told you, is what? Relaxation, okay? Now, if somebody have early labor, premature, you will give them what? A beta 2 agonist. But if you want to induce contraction, what you will give them? The opposing action is the oxytocin. It's not the para. And usually, remember when I give you that the sympathetic is opposing the parasympathetic, or the parasympathetic, then, and the effect, if you have sympathetic, in my first lecture, you can relate it now, that the sympathetic agonist, when you want to give the opposing effect, what will be if the other neurotransmitter, it should be parasympathetic agonist or antagonist? Okay, but now, will it be the medication is the sympathetic will give or parasympathetic? I don't know what Dr. Mula, I didn't check her. She gave you something which is related also to sympathetic. I think the pupil dilation, we use what? Atropine is used for what? What did she give you from the medication? You remember from cholinergic? Atropine is used, I'm sure that she gave you a muscarinic. So why we give atropine? Okay, and what do we give for the eye locally to cause dilation when they do fundoscopy, when they do any eye examination? Try to relate, honestly do a table so that you will not, now the sympathetic part is something. Before we leave, trust me, put the sympathetic, what are the major medication. Now I give you agonists, and when I give you the Thursday this weekend, just do a table for you. What are the most important for agonistic, sympathetic, and should we give something to add on the heart, should be on the sympathetic if you want to decrease the heart rate, or to be a beta 1 antagonist. Beta 1, and although the muscarinic is what? Muscarinic agonist is what? It's a Gartling what inhibitory, but we give a sympathetic antagonist. You have to see how it will act the sympathetics, and depending the places of these receptors, it could be bronchodilation, where it could be cardiac stimulant, okay? Now, GI, what will happen to it? Beta 2, we decrease motility. So now, should we give, usually, if we want to decrease motility, I'm sure Dr. Manashi covered it. We give a beta 2 agonist or a sympathetic antagonist. Go please and do this. Well, it will make it easier on you, okay? Remember my medication that was related to sympathetic, and see their effect, and which is better to give. Stimulant, will you give, and you want to stimulate the heart, and a selective one. Should you give beta 1 agonist or muscarinic agonist? beta 1 antagonist or M1 agonist. لا طبعا I doubt انه دكتور منى لكم muscarine you give it to inhibit the heart rate. And if you want to inhibit the heart rate, you give muscarinic agonist or you beta 1 antagonist. So both of them, the muscarinic is inhibiting the heart, but which is better to give it. So that's why you have to compare the antagonistic, and the antagonistic of the sympathetic is the same as what the parasympathetic. Go put this table, remember me, it will make it easy on you. This one, I put for you know whatever drug was mentioned in the lecture. I already mentioned the epinephrine, norepinephrine, azoprenamine, dopamine, dopitamine. I already mentioned phenylephrine, maybe methamphetamine. I did not mention clonidine. I mentioned it. Albuterol, salmeterol, formoterol. Yani these are all the medications that are used for the asthma. Amphetamine, I mentioned the ephedrine, pseudoephedrine. Yes, there are. You think few medication, but if you look at the table, most of these I covered it and where they're acting and their uses. This is a table to tell you what are the difference between catecholamine, what are the non-catecholamine, and synthesis. We have carbidopa, dopamine, bloxidopa, decarboxyl, and it's used in Parkinsonism. You will hear it. Storage, we have the reserpine, blocks carrier-mediated norepinephrine activation. These they were used, but dopamine you will hear about it a lot. I think this is the end. This is the last one where all the medication I already mentioned it. If you are talking about the dopamine or the blockers, the alpha or the uptake or anything. Yeah. By the more you go further, thank you so much. I think please remember to do a wrap-up for sympathetic or parasympathetic, especially the medication or the concept how they will act. Don't leave them until you have the exam. It will be like mixed. And at the beginning, we did not give you a lot of medication. When I already gave my MCQs, they are all on medication rather than mechanism of action. It's not like the one before the concept. Now it's more into medication. So please remember. So if I tell you which is the drug that will be given for vasoconstriction, what you have to remember? Epinephrine. If you wanted a cardiac stimulant from those medication and not the selective, dopamine, right? Then what about the nasal decongestion? Which one we give? Yes, salbutamol bronchodilation. Okay. Just you need to know this. What are those medications? Ephedrine, pseudoephedrine, they are fine. And go back home. I don't know if you have this, I like those, medications. You find it over the counter that have acetaminophen, cough syrup, or one time when I have two of my kids there, I'll just give them. They will have ephedrine or pseudoephedrine. Remember, and honestly, when I took this medication as oral, I will have increased heart rate. Side effects, mainly, you know it now. What is it? Heart rate. Remember the one I've used using of cocaine or amphetamine, what will happen? They will have the insomnia, tremors, headache. This is the one you stay over the night to study. Never ever do it. But although the amphetamine is used in ADD, as is an attention deficit disorder, yes, we will give them. What else? What will happen when you give asthmatic patient a beta blocker, a non-selective one? What you will give? Can somebody Sama? What will happen when you give asthmatic patient a beta blocker non-selective? Already we mentioned. Sama شكلك جيتي متأخرة يا Sama. Did I mention it or not? في حدا جاوب because بنحكوا مع بعض. Was the doctor doing by inside? Inside. What do I mean by inside or outside? حاططها في الصورة ما والكونت. I know what they mean by it. Can I tell you something? Honestly, you might miss something. I said it, or you were not focusing like some of you, they might order. You have to go and read from the book. You cannot depend on us. What do I mean by inside or outside? I remember it very well. inside the synapse or outside the synapse. Inside the synapse, what are the enzymes that are responsible for MOA? الكونت is what outside. This is what I meant. خلاص عم جاوبك. Please, you can send me any question you like, I can share it with them. But والله, I swear, it's for your own benefit, okay? Sometimes, not from you. From before, they send me, I don't want to say silly question, but this question is found in their book. They don't want even to read my lecture or to hear what I said. Just want to make it easy on them. Don't do it easy on you. You'll be one day a repeater if you do it like this. From now on, don't learn to read from the book, highlight your book, but then a million times I'm telling you, go back home and read my lecture. If you can explain it for yourself, it means you study it very well. And many of you, they said we studied very well, but we did not do well. And if you can rewrite it and do your own, whatever. Some people, they like figures, and I like figures and tables. I'm not into memorizing like a whole page. Give me a figure and table, I can memorize it. Maybe some of you know, some of you, they can memorize a whole paragraph. And it happens. This is differences between us. Okay, but don't leave it. When more medication is coming, well, these are the basic ones that we start with it. So best of luck. I'll give you maybe on Thursday. You have 9 to 10 adrenergic antagonists, and remember, it's given what mainly to block the heart. Thank you so much. You have questions? اصلا ودي اسال نادي لي اسمائكم
140
تعال نادي كمان هيك جعبالي لانه I know they will not attend تعال نادي بس if I ask for someone سعود البتيت يلا يا سعود وينك احمد هلا بجي
المشكلة المايكس مسكر
بس they should hear me right سعود جو مرام I'm against recording or I'm with, we have to call them, if we call them and they don't answer, they should be absent. بس خلاص يلا كورونا انتوا ايامكم. I was much more at the end it's your responsibility and your lecture. If you attend, you hear me. Some of you, they think if they can hear our lectures, it's okay. But let me tell you, when we write it, and before, because I knew they go and they said it's an easy lecture. And I give a direct lecture. Now I put it in a scenario. So whoever understands, he will know how to answer it. So now most of your questions from my side are in a scenario. So really you should understand. Because I knew the students, they think it's okay, easy lecture, easy to take it home, easy questions. Easy questions. Now I kept the easy lectures without recording. I'm against recording, but really, there should be a differences between you, and whoever study is not the same one as take last minute or whoever attend me. Thank you so much. Best of luck. And if you need anything, you can always email. Okay.